Hello. Today we'll be exploring clinical pathways for attachment disorders. Our presentation examines how early attachment trauma manifests across the lifespan and outlines evidence-based assessment and treatment approaches for clinical practice. This work aligns with the CACREP Section 5.C.2 Standards on Clinical Mental Health Counseling, focusing on developmental theory, etiology of attachment disorders, assessment, and evidence-based interventions. Attachment trauma involves traumatic experiences that fundamentally disrupt attachment bonding, initially with primary caregivers, resulting in impairments in core self and relational capacities. A clinical approach addresses attachment disorders by building consistent, trustworthy relationships with supportive caregivers or peers, aligning with clinical research. We engage in attachment-focused or trauma-informed therapy across the lifespan with recommendations for further research. And we develop self-regulation, emotional awareness, and relational skills through coaching or counseling across ethnic and minority groups. This framework guides our understanding of the specific clinical presentations we'll examine next. This table compares reactive attachment disorder, disinhibited social engagement disorder, normative attachment insecurity, and complex trauma patterns, linking their developmental histories to clinical presentations, differential diagnosis, and common comorbidities for practical clinical triage. While RAD and DSED are formally diagnosed in childhood, the attachment trauma patterns they represent persist well into adulthood, and that's when most individuals seek clinical help. As Ford noted, attachment trauma results in impairments in core self and relational capacities that extend across the lifespan. Walking through the row, let's start with the first row, RAD, the inhibited type. Typical history: children with RAD typically have histories of severe neglect and repeated caregiver changes, what the ACAP practice parameters describe as grossly pathogenic care. Core symptoms in childhood: we see withdrawn behavior, minimal comfort seeking, even when distressed. In adulthood, these patterns manifest as several intimacy avoidance, chronic relational withdrawal, and persistent difficulty trusting others, what researchers describe as pervasive inhibition of attachment behaviors that extend into adulthood, romantic and interpersonal relationships. Differential considerations: we need to rule out autism spectrum disorder, which can also present with social withdrawal, major depression, which shares the emotional flatness, anxiety disorders, and selective mutism. The key distinguishing feature is the direct link to early caregiving disruption. Common comorbidities: research in deprived populations found that children with RAD showed high rates of developmental delays, PTSD from chronic neglect, and depression. Children with RAD also met criteria for at least one other psychiatric disorder, most commonly depression and anxiety. This makes sense given the profound relational deprivation these individuals experienced. Walking the second row, DSED, the disinhibited type. Typical history: these children typically experience institutional care, neglect, or grossly inconsistent caregiving. They never formed selective attachments because caregivers were constantly changing. Core symptoms in children: we see overly familiar behavior with strangers, poor interpersonal boundaries, and what we call indiscriminate approaching anyone without appropriate wariness. Research shows that these patterns persist into adolescence and adulthood, presenting as boundary violations, impulsive interpersonal relationships, and chronic difficulty maintaining stable attachments. Differential considerations: ADHD can mimic the impulsivity. Mania presents with similar boundary problems and overfamiliarity. We need to consider cultural norms around interpersonal distance. What's overly familiar varies significantly across cultures, and differentiate this from acute trauma reactions where someone might temporarily lose appropriate social boundaries. Differential considerations: common comorbidities. These cluster around externalizing problems, ADHD, oppositional defiant disorder, anxiety disorders, and conduct problems. Research also shows elevated rates of bipolar disorder with attachment insecurity, mediating the relationship between early trauma and mood instability. This reflects the profound dysregulation that comes from never developing organized attachment strategies. Common comorbidities. This isn't the third row, attachment insecurity. This isn't a disorder, it's a variation in attachment style that can develop even with adequate care when stress or temperament factors are present. Typical history, core symptoms, these individuals show avoidant or ambivalent patterns, primarily under stress, not the pervasive severe impairment we see in RAD or DSED. This is developmentally normal variation in how people handle attachment relationships. Differential considerations. The key here is recognizing that this is not a disorder. We need to consider developmental context and age appropriateness. We're looking at adaptive variations in attachment styles, not pathology. Comorbidities, because this is normative, comorbidities are variable, but some individuals may experience anxiety or behavior problems depending on life stressors, but there's no consistent pattern like we see in the disorder categories. Fourth row, complex trauma pattern. We most commonly see in adults' clinical counseling settings. Typical histories involve chronic interpersonal threat or neglect, not necessarily the extreme institutional deprivation of DSED, but sustained relational trauma over time. The core symptoms: adults present hyperarousal, emotional dysregulation, and profound relational mistrust. This is what Herman described as complex PTSD, the results of prolonged, repeated interpersonal trauma. Differential considerations: we need to differentiate complex trauma from PTSD. Though there's significant overlap, mood disorders which share this dysregulation, the dissociative disorders which can emerge from severe chronic trauma. Common comorbidities in older youth and adults, we see PTSD, depression, paranoid ideation, with anxious attachment styles strongly predicting paranoid thinking, and narcissistic personality disorder with up to 80% comorbidity with borderline personality in attachment traumatized samples. Substance use disorders are also elevated as individuals attempt to manage attachment relational emotional pain. Now, how do we do clinical triage and treat the presentations? The ACAP parameters emphasize structured assessment across multiple contexts. For younger clients, this includes direct observation of caregiver-child interactions. For older adults presenting in clinical counseling, we conduct detailed attachment histories, interviews, assess current relational patterns, and evaluate the link between early caregiving disruption and present-day symptoms. Treatment must address the core attachment disruption through relational-focused interventions. Research demonstrates that attachment-based psychotherapy and mentalization-based treatments provide corrective relational experience that helps patients develop more secure attachment patterns. Trauma-focused interventions targeting the traumatic memories underlying relational fear have shown effectiveness, particularly when combined with skills training for emotional regulation and interpersonal effectiveness. DBT has demonstrated particular value for the emotional dysregulation we see in DSED and complex trauma patterns. What not to do. The ACAP parameters explicitly state that coercive interventions like holding therapy or rebirthing are not endorsed and can have harmful effects. Treatments must be relational, trauma-informed, and focused on building safety and trust, not replicating the coercion that these individuals already experienced. Outcomes. Research examining adult outcomes of children with RAD found elevated psychiatric comorbidities and functional impairment, including lower educational attainment, higher rates of psychopathology in adulthood. However, early relational interventions significantly improved trajectories. The inhibited pattern often resolves more readily than the disinhibited type, which tends to persist longer than treatment. Levy found that even in severe cases with comorbid personality disorders, attachment-based treatment produced significant improvements in reflective functioning and symptom reduction, demonstrating the attachment patterns can shift with appropriate intervention. The clinical takeaway: recognizing these patterns, providing accurate differential diagnosis, and implementing evidence-based attachment-focused treatment can fundamentally alter the life course for individuals carrying attachment trauma into adulthood.
Understanding the complexities of attachment disorders is essential to counseling, as it can inform counselors about the underlying causes, comorbidities, and challenges in intervention, thereby enhancing the client-counselor relationship and therapeutic outcomes. Attachment disorders are classified as trauma and stress-related disorders, meaning they are associated with extreme neglect, maltreatment, and disruptions in early caregiving. Pathogenic care is the driving force that contributes to the formation of attachment disorders. This includes failure to provide physical needs such as feeding, hygiene, and safety, as well as lack of caregiver emotional response such as attunement and soothing. Developmental settings are also a contributing factor, like those of institutions, foster care, and orphanages that lack consistent care due to frequent changes in caregiver. Reactive attachment disorder is characterized by an inability to form emotional attachments, reduced capacity for positive affect, and fluctuations in emotional disposition. These clients often struggle with trusting others and are more likely to internalize problems such as depression, anxiety, low self-worth, and suicidal ideation. On the other hand, disinhibited social engagement disorder displays patterns of disinhibition, including lack of reticence toward strangers and crossing of social boundaries. Clients will appear overly comfortable and will often struggle with externalizing behaviors such as impulsiveness, attention deficit hyperactivity disorder, conduct disorders, and oppositional defiant disorder. Individuals with attachment disorders often show symptoms of other psychiatric and psychosocial disorders. One study found that 65% of reactive attachment disorder diagnoses met the criteria for at least one additional psychiatric disorder. Of those diagnosed with disinhibited social engagement disorder, 90% met the criteria for at least one additional psychosocial issue. By recognizing the distinctive characteristics of attachment disorders and the associated comorbidities, counselors can conduct more accurate assessments, inform trauma-sensitive intervention plans, and strengthen their therapeutic alliance. Notable clinical implications for counselors working with clients who present with relational trauma center on differential diagnosis and social cognition. Attachment disorder symptoms frequently resemble other psychiatric conditions, making accurate differential diagnosis essential. Without careful assessment, clinicians may overlook underlying attachment disruptions and focus only on surface-level behaviors. Research emphasizes the importance of identifying comorbidities to gain a comprehensive understanding of the client's overall functioning and to determine appropriate interventions. Equally important are the social cognitive impairments central to attachment disorders. Clients often demonstrate mentalization deficits, distorted inner working models of relationships, and identity disturbances or diffusion. These patterns shape how they interpret social interaction and form relationships. Maltby and Hall highlight that counselors can provide a secure base within the therapeutic relationship. Through consistent, attuned engagement, clinicians can create opportunities for corrective attachment experiences that gradually reshape maladaptive relational patterns. Research across cultural contexts suggests that attachment disorders are not limited to any specific culture, but instead highlight a universal response to severe relational stress and trauma. For counselors in a culturally diverse nation, a greater awareness of cultural norms, systemic influences, and generational trauma inherent to minority populations is crucial for understanding the factors that contribute to relational deprivation, as well as the perspectives that shape optimism and resilience. With greater understanding, clinicians can provide accurate and culturally responsive assessments and care while advocating for systemic changes that reduce the aspects that cause attachment disruptions. Wilson, 2001, highlights caregiver factors such as parental depression, isolation, lack of social support, and generational trauma that contribute to caregiver deficits later affecting their own children. Although Understanding of attachment disorders with cultural and systemic context specific to each client allows counselors to move beyond simply addressing symptoms and toward equitable, trauma-informed, and culturally responsive care.
Evaluation of the problem within mental health counseling practice. Evaluation. Trauma often disrupts a person's attachment system and spiritual life, creating complex emotional and relational difficulties. From a clinical perspective, trauma frequently produces symptoms such as emotional dysregulation, hypervigilance, shame, and avoidance. Attachment therapy provides an essential framework for evaluating the problem. The therapeutic relationship itself becomes a primary intervention. Evidence-based interventions and treatment approaches. Evidence summary. RAD and DSED case studies have shown that long-term therapy and a spiritual framework address the deep-seated disconnect between patients' internal trauma and external communication. Early relational adversity impacts long-term mental health. Key goals and treatment approaches. Increase awareness of attachment wounds, process unresolved trauma, develop a more secure relational template, improve affect regulations. The strategies that can be used is exploration of painful memories, naming and validating emotional experiences, tracking emotional responses in sessions, encouraging embodied emotional awareness.
Conclusion: attachment care pathways. Some team perspectives. Healing is relational. Therapy builds reflective functioning, compassion, and forgiveness. Consistent, attuned care helps clients process attachment wounds and develop secure relational patterns. Attachment trauma is universal across cultures, but shaped by cultural norms, systemic factors, and generational trauma. Culturally responsive assessment and advocacy are essential for accurate care and long-term prevention. A project summary. RAD and DSED stem from early relational trauma disrupting attachment bonds, emotional regulation, and internal working models, core beliefs about self and others. Symptoms often overlap with ASD, ADHD, PTSD, and mood disorders. Careful differential diagnosis is essential. Evidence supports attachment-based therapy, trauma-focused treatments, DBT-informed skills, and caregiver interventions. EMDR, imagery rehearsal, and paced breathing show promising support for trauma processing and regulation. Future directions and recommendations. Clinical focus. Expand attachment-informed and caregiver-based interventions. Integrate practical regulation and trauma processing strategies. Strengthen dyadic and relational treatment models. Prioritize culturally responsive assessment and advocacy. Some ideas for possible further research needed. Long-term outcomes of attachment-focused therapy, neurobiological markers of attachment repair, role of spirituality in attachment recovery, development of structured, integrated practical exercises, significantly more research on minority populations and attachment disorders as current literature is limited in this area. Closing thought. Attachment trauma is relational, and so is healing.